the brief instructions for interpretation. As you know, Heart's webinars have simultaneous interpretation into English and Spanish. We would like to ask you all to select the language of your choice, which can be located at the lower part of the screen in the menu bar, where you find an icon in the shape of a globe with the word interpretation. Just choose your language, and also please make sure to keep your microphones muted throughout the session so that the speaker can turn on his microphone when beginning his presentation. You can send a greeting through the chat. You can say what country you're from, as many of you have already done, and you can use the Q&A section to ask your questions, which we will be answering throughout the webinar. With no further ado, and we want to do the best we can with what technology is giving us today. It'll be radio-like, but in any case, we will have a great webinar. And I'd now like to give the floor to Dr. Pedro Ordúñez from PAHO headquarters in Washington. Dr. Ordúñez, you have the floor.
Gracias,
Thank you, Gloria. And thank you all colleagues for this introduction. I would like to welcome you on behalf of the Pan American Health Organization here in Washington. We're on our Hearts webinar in the Americas. And today we're dealing with the topic of standardized treatment protocols for hypertension. And this combination and partnership with the Strategic Fund of the Pan American Health Organization, with a single idea in mind of how to improve access to health and universal access to health, how we improve the quality of care, and how do we recognize the new opportunities to access quality medicines at competitive prices. So today's webinar is on the following basis. If we're able to have standardized protocols and quality medicines, and those quality medicines are accessible, then we have a good opportunity of having successful programs. Today, we have a program, a luxury program, if you wish, as we often say. Today, in the old-fashioned way, as Gloria said, we are having trouble with the cameras. We're not being able to turn on the cameras, but we will have the slides on the screen, so you will be able to follow the presentations and hear the speakers who are with us here today. Our first session will have a review of the algorithms. Well, first, the first presentation will be, why do we need treatment acronyms with this acronym of SAANE to improve global control of hypertension? And let me tell you something. Why do we need standardized algorithms? Why do we need algorithmic algorithms accessible or affordable that are non-toxic? And I'll explain, we'll explain later what non-toxic means, and effective. And for this today, we have Dr. Jennifer Cohn, who's Vice President of Cardiovascular Health from Resolves to Save Life. Dr. Cohn has an enormous experience working in this type of protocols, and also brings us the experiences she gained in AIDS and HIV, as we've said in the past. And she represents Resolves, which is one of our main partnerships with Hearts in the Americas. And then the second presentation will be Dr. Donald DiPetti, who's very well known by the Hearts public. who's going to talk to us about the HEARTS methodology for the transition of existing treatment practices to the best practices using pharmacological protocols. This is going to be the first part of the webinar. And in the second part of the webinar, we'll show the next slide. The second part will have the head of the Strategic Fund for Public Health Supplies, Christopher Link, who's going to introduce two very important topics with his colleagues. One, the inclusion process in the strategic portfolio, in the strategic funds portfolio for medications for treatment of hypertension, as well as the procurement mechanism through the PAHO strategic fund. The first will be by Dr. Murilo Freitas, who's an expert in pre-qualification, and the second is Jordi Ballesta. I'll introduce them later in detail, but I just wanted you to have an idea of what today's agenda was like. The first part, as I said, will deal with the protocols, and the second part, the topic of the list of essential supplies, and the entree, let's say, will be the prices of medications obtained by the PAHO Strategic Fund for strategic inputs of PAHO for anti-hypertension drugs. So with no further ado, I'd like to, it's a pleasure, I should say, to introduce Dr. Jennifer Cohn, who's cardiovascular health, president of cardiovascular health of Resolve to Save Lives. Dr. Jennifer Cohn, welcome. And the floor is all yours.
Wonderful.
Jenny, please.
Thank you so
start
much.
your presentation.
Should I share my presentation?
Jenny Vallejo, sube la presentación.
Yes, Jenny Vallejo will now turn your presentation on.
Sorry, too many Jennifers.
Yeah, no, there are too many Jennifer. That's true.
Great.
Yeah. Well, I think I have, in my list, I have 10 Jennifer in this class. But I don't know. But I'm sure that Jenny Vallejo is just one in Washington, and Jennifer Cohn is the vice president of Resolve to Save Lives.
Wonderful.
So the floor is yours, Jennifer.
Thanks so much. Thanks so much, Dr. Ordonez. Really appreciate it. And I just want to say thank you so much for inviting me to speak on behalf of Resolve. I'm so excited about all the speakers and topics at this webinar, and I'm really looking forward to the discussion. Just to say that PAHO has been a real leader in the HEARTS rollout, incredibly impressive work, and in particularly with respect to strategic medication rollout and procurement. So I'm just delighted to also learn from you all. Next slide, please. All right, so as everyone here knows, cardiovascular disease is the #1 killer of people worldwide, and hypertension is the leading modifiable risk factor. Unfortunately, despite the fact that we have effective medicines to treat hypertension, globally, most people with hypertension do not have it under control. It looks like people are not understanding me because I'm speaking in English, but I believe there is translation. Is the translation happening?
Yes, we can hear you. It's fine.
Okay, great. Okay, I'll continue.
Yeah, it's working perfectly.
Okay, wonderful. Just wanted to check. Okay, great. So globally, most people do not have their hypertension under control. It's only just 14% worldwide. And when we look specifically at low and middle income countries, we only see that 10% are under control. Now, this is an unacceptable situation and one that Resolve has been working on in close collaboration with PAHO, as Dr. Ordonez mentioned, and they have been an absolutely fantastic partner. Next slide, please. At Resolve, we really feel that focusing on hypertension control can actually serve as a pathfinder to defining interventions to reach universal health coverage. Resolve has supported adaptation and implementation of the WHO Heart's hypertension model, which includes drug and dose-specific protocols for treatment, quality assured drugs and equipment, and making sure that these are accessible down to the facility level, focusing on team-based care, which includes task shifting to less specialized healthcare workers, patient-centered services, including decentralization, appointment spacing, and multi-month refills, and systematic monitoring for continuous program improvement. Now, in the next few minutes, I'd like to focus just on the power of simple algorithms, what I will call sane algorithms, and how they can unlock a revolution in care delivery that can enable the scalable and effective delivery of hypertension care. Next slide, please. And we really need this revolution because we're up against a lot of barriers. Even in Resolve-supported projects, we see suboptimal treatment and control. In particular, we often see high rates of loss to follow-up. However, where we and our partners have started to push the envelope to really realize change in our care delivery models, we've seen enrollments, retention, and control rise. Specifically, we've worked to address poor access to care due to centralized systems by working on poor access to care due to centralized systems by basically looking at decentralization of diagnosis, treatments, and care down to the primary care level and even to the community level. We've also looked at how to address constrained human resources that have come about through a lack of task shifting. And we really feel that these simple algorithmic care guidelines can enable task shifting to less highly trained healthcare workers. Unfortunately, we often see that the models of care are not very patient friendly, which means that patients often have to come back very frequently. And so what we want to move to is something where we can simplify treatment and allow for visit spacing, multi-month refills, and even use of fixed dose combinations to reduce pill burden. And then finally, as this webinar is about, there's poor access to medication and also lab monitoring. And that's in large part because there's poor market consolidation. What we need is simple treatment algorithms that allow for just a few medicines that will lead to reduction in prices and also streamlining procurement and supply chain. Next slide, please. And so what many of us think can enable improvement is what I am calling sane algorithms. And the acronym for SANE is simple, algorithmic, accessible, non-toxic, and effective. And these sane algorithms can really help reduce barriers to scale and effectiveness of hypertension care at multiple levels for the health system, for patients, and for payers. Next slide. And here's an example of a sane algorithm. It's simple and it's algorithmic. It has minimal steps. It has clear and specific medications and dosages. It's accessible. It uses affordable medications that are readily available on the market. It's non-toxic. It uses medications that have minimal side effects and lab monitoring. And this wide therapeutic index can also really allow decentralization and task shifting. And it's effective. It's been shown to achieve and maintain control. But the real power of these sane algorithms is that they enable a number of other key interventions that help build systems that are beneficial and sustainable for patients, health systems, and payers. Next slide. So first, let's discuss how sane treatment algorithms can support health systems. It's not news that in many low and middle income countries, there is a shortage of human resources for health. So as we scale up programs, whether it's for HIV, hypertension, or integrated primary care, we need to make sure we're using scarce resources rationally. And Sane algorithms can help us do just that. They essentially can enable significant task sharing to nurses or even community healthcare workers because they are simple to train on how to use. They follow very simple steps, and they also have, because of this, have the ability to reduce therapeutic inertia because the clinician knows exactly what to do next. And again, the fact that these are safe with low side effects means they have a wide therapeutic index, and it minimizes risk, again, enabling task shifting. And not only is task shifting good for health systems, it turns out that this sort of algorithm-based task shifting for patient management is good for patients as well. So this forest plot represents a systematic review. And in this systematic review and meta-analysis of task shifting for hypertension from the Lancet Global Health, studies that compared task shifting, including those using algorithm-based care for patient treatment, resulted in better hypertension control versus the standard of care. We've also seen this in other areas like HIV. And that's because Sane algorithms can facilitate task shifting and decentralization, bringing care closer to patients. And it facilitates decentralization all the way down to the primary healthcare level. Again, this brings care closer to patients, makes it easier for them to access, reduces transport cost and wait times, and improves retention in care and control. In Resolve-supported projects, one of the most powerful interventions we've seen to increase control and retention rates is actually this decentralization of care, which again is facilitated by Sane algorithms. Next slide. And Sane algorithms can also help improve access to treatment by bringing down medication prices and increasing the consistent availability of medicines. Right now, the current hypertension situation is characterized by unaffordable medications. About a month of hypertension medications across many low and middle income countries cost more than 10% of a worker's monthly salary. Unpredictable supply. In a survey, only 7 to 26% of public sector facility had basic hypertension meds in stock. And a fragmented market with many different single medications and many different fixed dose combinations, which doesn't allow for leverage. Now, we can get to a more consolidated market through Sane algorithms because Sane algorithms limit the number of drugs that a given purchaser buys. And this means that they can increase volumes, increase their purchasing power for buyers, and also manufacturers can achieve economies of scale. It also simplifies forecasting and supply chain, including right down to the last mile, the healthcare facility. And it allows for increased predictability, and so that healthcare facilities can stock sufficient amounts of medication for multi-month refills. And now use of fixed dose combinations at any step can actually also further simplify the supply chain. Next slide. Finally, from a health systems perspective, use of Sane algorithms enables care where laboratory resources are constrained. For example, a Sane algorithm that starts with a calcium channel blocker may reduce or eliminate the need for laboratory monitoring. Algorithms that use ARBs or ACE inhibitors earlier in the algorithm may allow for just initial lab testing to document if a patient has normal creatinine clearance or not, and allow for only ensure lab monitoring is done for those with abnormal or low creatinine clearance. Next slide. And as I mentioned a couple slides back, Sane algorithms enable decentralization, but they can also enable use of critical tools for patients, multi-month refills and visit spacing, especially for patients who've achieved hypertension control. In many countries, patients are only given a week or two of medicines and asked to return to the health facility for frequent visits. This puts a huge burden on patients in terms of both time and out-of-pocket costs. Especially for a typically asymptomatic disease, this is not a good setup for retention and care. And across Resolve's programs, we see the biggest gap for patients who are enrolled is actually lost to follow-up. So we need to focus on interventions that allow decentralization and patient-friendly models. By streamlining procurement and supply chain systems to focus on a limited number of key drugs for a sane algorithm, we can get to a situation where each clinic can reliably stock sufficient medicines to provide multi-month refills to patients. And while we don't yet have a lot of data from hypertension programs, we do have excellent data from similar chronic disease, HIV. HIV programs have focused on visit spacing and multi-month refills as a key way to create patient-friendly care and offload busy health clinics. This study from Clinical Infectious Diseases shows an association of the visit schedule on retention and care and medication gaps in a large cohort of stable HIV-infected patients in Zambia. And basically, longer visit intervals with multi-month refills were associated with better retention in care. Next slide. And finally, payers. Whether a program is funded by donors, governments, or by patients themselves, every penny counts, especially in the current fiscal environment. Sane algorithms help maximize efficiency by allowing reducing costs for medications, by shifting to more affordable models of care. And just to return to HIV for one final example, this tornado chart shows how use of algorithm-driven task shifting and visit spacing with multi-month refills actually reduced costs across a number of different things, from the cost of the antiretroviral medication to the cost of lost patient times to healthcare worker cost, et cetera. So we can really reduce costs by getting to these sane algorithms. Next slide. So in conclusion, it's really time that we unlock the potential to scale effective hypertension programs. PAHO is leading the way in many, many ways by doing this, but there's also an urgent need for specific sane algorithms, both from normative guidelines and in national guidelines. And just to note that sane algorithms are just the first step. We have to follow through with market shaping, improved models of care, and decentralization. Thank you so much.
Bueno, excelente presentación de la doctora Jennifer Cohn de Resort to Save Life, vicepresidenta.
Oh, excellent. Thank you, Dr. Jennifer Cohn. This was an essential topic, and thank you for your very clear presentation. I would like to continue to insist on this. Let us remember that many of our countries having access to hypertension medications and having access to quality medications and have them available and make them affordable is a problem. And it is even more important for those who need it the most, those who can the least afford medications, and also for the ability of health system management issues. We have more than 200 people connected to this webinar, and we have people from almost all countries of the region. Let me tell you to please use the chat for questions that you want to address to Dr. Cohn. We will have the Q&A after the second presentation. Now we need to focus on how the countries can adapt their treatment protocols to some protocols that meet the conditions explained, the sane protocols, that they are simple, algorithmic, accessible, non-toxic, and effective, as was explained to us by Dr. Cohn. And for this, to help us continue to think about this, I invite Dr. Donald DePetty, who is one of the pioneers of the HEARTS initiative. He's well known by all in our region. He's a distinguished professor of medicine from the University of South Carolina. And it is an honor to have Dr. DePetty with us. And So we should now, I ask Jenny to please place Dr. DePetty's slides.
The first thing I want to ask is, Jenny, I don't see my presentation on my screen.
Hi, Don, just a few minutes, just a second.
Oh, there we go. Something happened. There we are. Thank you. Pedro, thank you very much for the kind invitation to join the group. I see there's over 200 individuals on the webinar, and I can't be more thrilled. Dr. Cohen just talked to us about mostly why, and then of course, how to move to increase control of hypertension. What I'm going to center on is, number one, reinforce the why, but mostly concentrate on the how to do it in terms of transitioning from an existing treatment practice to potentially, and of course, ultimately best practices using pharmacologic protocols. Jenny, next slide, please. Dr. Cohen already showed us this slide. And of course, this is not anything that none of us on this webinar don't already know. The poor control globally, mostly in low to middle income countries. But I want to share a new urgency, and that urgency is in high income countries. Next slide. This data came as quite a shock to many of us. This is data, hold on 1 second. Oh, start, okay. Let's do that. Sorry, I'm gonna share the video. There we go. Thank you, Jenny. This data came as quite a surprise. And again, we've been centering through the various programs for the last 5 to 7 years on low to middle income countries. But I'm going to make a passionate plea that this is a global urgency, including high income countries such as mine, the United States. Up until recently, in the 2013 to 2014, our population survey, which is called NHANES, the NHANES data, we've seen increasing control rates in the United States, as well as other westernized countries, approaching about 54, 55%. The urgency, however, has recently come. In our last NHANES report, which was only published last year in JAMA, we've now, for the first time in many decades, seen an actual decrease in hypertension control rates in the United States. That's using criteria of less than 140/90, and the control rates have decreased about 10% over a short period of time. However, if we embrace other criteria, more stringent control rates of less than 130/80, the hypertension control rate in the United States is a dismal 19%. This would be an urgent message in itself. However, we're also seeing a commensurate decrease in major cardiovascular event rates, such as stroke, that is commensurate with this decreasing hypertension control rates in my country. This is such an urgency that if we looked at the next slide, our Surgeon General just recently put out an 80-odd to 89-page call to action to renew our vigor for hypertension control rates in the United States. It's on the Surgeon General's website, and it's recently last year. The overall goal was to avert the negative health effects of hypertension, of course. There were 3 sub-goals. 1, make hypertension control a national priority. 2, ensure that places where we live, work, play, etc., support hypertension control. But more importantly, the goal number 3 was to optimize patient care for hypertension control. And the number 1 strategy that was outlined in the Surgeon General's report, again, in a high-income country, was to advance the use of standardized treatment approaches, including hypertension formularies and treatment protocols or algorithms. Next slide. Well, let's now talk about how. That's the burning platform. And if we're going to have a paradigm shift in the way we approach any entity, the number 1 necessity is a burning platform. We've already seen from Dr. Cohn and the Surgeon General's report and our decreasing hypertension control rates in high income countries, there is clearly a burning platform. Well, the treatment of hypertension is not an old therapy, if you will. It's in one generation. In the 1950s to 1960s, we didn't have evidence-based medicine to suggest lowering blood pressure does any good. And even if we did, we had poor pharmacologic antihypertensive agents. As evidence-based medicine became available and other medications became available, we initiated the therapy of hypertension. And the initial efforts revolved around the concept of stepped care. Stepped care was just basically start with one medication. In the initial step care approach, it was a thiazide or thiazide-like diuretic. Maximize the dose, start a second agent. If necessary, maximize that dose, start a third agent, et cetera, et cetera, et cetera. That then moved on to a little bit of a change to individualized care. The concept of step care was still the foundation. Start with one agent, maximize the dose, add another agent, maximize the dose. However, this phase, which I believe, and I would submit to you we are in now, allowed individualization in that the initial medication could be one of several antihypertensive classes. What I would like to argue for, and what we're seeing around the world and globally with Resolve, with Hearts, et cetera, is a population-based approach, where we actually take a population-based approach regionally, if you will, but potentially even globally, to develop a therapeutic regimen, a therapeutic approach to take care of everybody, irrespective of geography, irrespective of demographics, irrespective of ethnicity, race, et cetera. And let's talk about that and how we do it. Next slide. Well, we've always had key elements to delivering support and care to increase hypertension treatment and control. And I like this slide because it reminds me from the very initiation of a programmatic population-based approach, medications were core. And that medications were furthermore standardized, broadly available, and integrated into comprehensive formularies and treatment algorithms or protocols. This is not new in Hearts. This is not new to many of us. However, now we need to talk about how we do it and how can we do it quicker or more rapidly. Next slide. Well, as Dr. Cohen suggested and already demonstrated to us, there are many, many barriers. But using a standardized formulary and treatment protocol overcomes many of the present barriers to hypertension control. Number one, it addresses poor adherence to treatment, as we've already seen. Number two, it clearly improves therapeutic inertia. And therapeutic inertia may be the single most reason why we are not pursuing hypertension control rates with more vigor. It also addresses lack of adherence to treatment guidelines. There's plenty of guidelines, it's just that they're not followed to a large extent. And lastly, it does improve issues and addresses issues to supply, distribution, and cost, as Dr. Cohen already so eloquently demonstrated for us. So there's many, many reasons as to why. How about how? Next slide. Well, most guidelines in hypertension, guidelines globally and regionally recommend one of three classes of medications for the treatment of hypertension. Diuretics, particularly thiazide and thiazide-like diuretics. RAS or renin-angiotensin-aldosterone system inhibitors, such as ACE inhibitors or angiotensin receptor blockers. And finally, calcium channel antagonists. Next slide. I specifically like to mention and talk about beta blockers because some guidelines still include beta blockers. However, most now are moving away from beta blockers as an independent initial agent to lower blood pressure. However, they should still be included if there are compelling reasons and indications for a beta blocker independent of blood pressure reduction. Next slide. Well, let's start with what would be the ideal characteristics of an individual medicine if we were to develop one and put it into our treatment approach and or our treatment protocol or algorithm. This is adapted from one of our initial papers of the group on the standardized hypertension treatment program that was published in 2016. Number one, of course, many of these are intuitive. Has to be effective, has to be safe and well tolerated. It must be supported by evidence-based clinical trials. And clearly it has to be affordable and available or it's of no use. A particular characteristic would be a once-a-day formulation for adherence, et cetera. And an additional one could possibly be that it comes in a scored tablet in differing doses where you might permit pill splitting to save funds, money, et cetera, and economies. Next slide. But that would be the ideal characteristic of an individual medication. However, as we're seeing, hypertension control rates are dismal. They're decreasing perhaps even in a country such as mine. What are some of the initial advantages of using combination therapy, either in the form of 2 single pills, or better yet, in a fixed dose combination or a single pill combination formulation at the get-go as the initial treatment step? Number one, the data is clear. Most patients with hypertension will need multiple drugs to achieve blood pressure control rates. That was true with a blood pressure, a goal of 140/90 or less. It's going to be almost sacrosanct, if you will, if we're going to use control rates of even lower, such as 130/80. Number one, and number two, there's greater efficacy of using 2 complementary antihypertensive agents together. They're either additive or they're synergistic. It lowers the doses of the 2 medications when they're chosen from complementary agents. They're also more effective than the single dose at the higher maximal dose, if you will, and they can mitigate or reduce side effects of each other, not only by dosage reduction, but by picking and choosing complementary classes. Clearly, they lead to better adherence because it's a simplified treatment regimen, reduces clinical inertia, as we've already discussed. And I think this is the most important aspect of choosing combination medications if we're going to have a population-based approach. If we're going to have a regional or global approach, the 2 agents that we should choose should lower blood pressure equally across a diverse demographic groups, if you will, and choosing 2 complementary classes does that. The evidence is clear. And again, it would be really nice if we could lower the healthcare costs with fewer office visits, and the data is becoming clearer that despite the initial pharmacologic acquisition cost, the long-term costs are beneficial. Next slide. Now that we've talked about the individual medications and classes, what would be the ideal characteristics of a combination of 2 medications? Well, some of them are going to be similar to the individual characterizations. This was published recently in the Journal of Clinical Hypertension by a large group of us in 2019. Again, they should be highly effective. They should be additive and synergistic in blood pressure reduction when used together. They should be supported by clinical trials. Hopefully, they would mitigate the side effects of each other. They should be widely available and affordable, just like each individual agent. And again, already mentioned, they should be safe and efficacious in diverse demographic settings across race, ethnicity, sex, geography, if you will. So if we're going to choose 2 medications, which 2 medications should we choose to put together? A group of us got together, and again, in this publication suggested that a renin-angiotensin system inhibitor and a calcium channel blocker combination should be preferred. In this order, the angiotensin receptor blocker CCB combination, followed by the ACE inhibitor CCB combination. And the reason the angiotensin receptor blocker is chosen first is because of side effects and tolerability. You could also choose an angiotensin receptor blocker and thiazide, or thiazide-like diuretic, or the ACE inhibitor, thiazide or thiazide-like diuretic combination. And again, the ARB is put above the ACE again for side effects and tolerability. We grappled over the CCB thiazide diuretic combination and said it's not preferred in addition to others, solely because at that point in time, including probably to today, that there's limited evidence-based medicine for this combination, but there's many, many studies ongoing and this could change. Next slide. So how are we going to do this? What we would propose is first, take a stepwise approach. Select the preferred and acceptable pharmacologic drug classes that are available. Following selecting the classes, select the individual agents within each class. And you can have a primary agent and a secondary agent, for instance. And finally, you have to be able to get these medications and deliver them. So select which preferred and acceptable combinations are available and affordable at a local level. Next slide. So now the question becomes, how are you going to implement that? And this publication that is in your reference list for this webinar was just recently published in 2020, again, by a large group. You can see the authors. And the manuscript objective was really targeted. It was to describe the how to adopt and transition to a standardized hypertension pharmacologic treatment protocol or algorithm, and keeping it consistent, of course, with HEARTS. And the HEARTS module that's most applicable, of course, is the E module for evidence-based protocols. Next slide. Well, when we first discussed the how, one possibility is to just jump right in and I want the very best, I want the very preferred hypertension algorithm that I can have. And that would be wonderful if that could be implemented from day one. On the other hand, however, that's unlikely in most geographies, countries, regions, etc. So start somewhere. So the clear recommendation, of course, is to develop a stepwise, staged approach that allows a transition from the current protocol that can be developed and put in place today using the medications that are available, affordable, etc. At the same time, however, thinking in multiple directions, and how would you move to an acceptable protocol? An acceptable protocol is a quasi-definition where the agents would have more characteristics of the individual ideal characteristic of the medication. The agents that would have all of the ideal characteristics that were defined both for the individual and for the combination. That would be the preferred protocol. Of course, that may take more time. It may take 1 to 2 years for drug procurement, reaching consensus, and again, developing the rationale and the how and the why. The thiazide diuretic hydrochlorothiazide is still not controlled, and then double the dose of all 3 medications. This is this could be a current protocol. It also could be an acceptable protocol. However, it's not ideal. It's not preferred. Why? Number one, losartan is a short-acting angiotensin receptor blocker. And thus, it might be more ideal if the angiotensin receptor blocker was a true once-a-day formulation, and once-a-day formulation for pharmacodynamics, not just by measuring pharmacologic blood levels, if you will. And secondly, the thiazide-like diuretic is hydrochlorothiazide. Some may argue that a preferred thiazide diuretic or thiazide diuretic could be chlorthalidone, for instance. Again, this is just an example. Next slide. So even though the algorithm on the protocol on the left, if it could currently be put in place, it should be, and it should be put in place immediately. It might already be an acceptable protocol to some. However, while that's being done and put in place, we can also start the process to transitioning to a preferred or an ideal protocol shown on the right. And again, this is only to serve as an example. In this protocol, which is termed preferred, if you will, and beauty is in the eyes of the beholder, this is all individual. The losartan, a shorter acting ARB, is replaced with telmisartan, a longer acting, true once a day pharmacodynamic ARB, if you will. The amlodipine is left the same. On the other hand, also, the hydrochlorothiazide has transitioned to chlorthalidone at equal pharmacokinetic and pharmacodynamic doses. This transition may put in place practice and treatment. While we're developing a small, specific medication formulary that is targeted at the primary healthcare level, which clearly consists of the recommended classes of antihypertensive agents. At the same time, we would want to implement a straightforward pharmacologic treatment protocol, which uses combination therapy, either in a fixed dose or in 2 single pills, if you will. The fixed dose would be better for adherence and persistence, but starting at half maximal doses in the initial hypertension treatment step, because then it only requires 1 up titration of the agents. And finally, let's do today's work today. And we'll also consider tomorrow's work today as well. Let's employ a stepwise approach to protocol development. Start with a protocol that can immediately be put in place currently. It also may be your acceptable protocol. If not, transition and start planning towards an acceptable protocol and ultimately to a preferred protocol using the existing medications that are available and affordable and at the local, regional, and of course, hopefully even a global level. Last slide. Again, Dr. Dunas and group, I am just honored to be part of this group. It's been a wonderful journey. I've been blessed to be at the beginning of the journey, and I can't thank you enough for having me and having me part of the team.
Muchísimas gracias, profesor De Petty. Como siempre, excelente su presentación.
Thank you very much, Dr. De Petty. Your presentation is excellent. We have a combination between Dr. Cohn and Dr. De Petty telling us, yes, it's time for us to change things. Right now, it's 16 countries in the region are implementing the strategy right now. We have Bolivia, Brazil, Guyana, and British Virgin Islands. We have 4 countries out of the 16 that are implementing HEARTS, and we have several hundred healthcare centers implementing this. And our projection is to go to 75,000 health centers by 2025, and this just in 16 countries. So it is a very serious, frequent, common problem. We need to find more common solution, more practical solutions. Jenny and Don, we have officials from the health ministry, we have clinicians, we have professors, and we have those who implement the initiatives at primary health level. But they are still having challenges because they don't know how to manage things. During COVID-19, many countries have had stockouts of medications, and they have had no way to replace the medicines. And many of the patients suffering from chronic diseases have not had medications, even though we knew that they are at very high risk during COVID-19. I have a question for Dr. Cohn. We have some officers of health ministries, and we have acquisitions or purchasing officers. So my question is, why should we transition now from this open bar approach where you have a whole series of 20, 30 medications? Health ministries have to guarantee 30 agents for 30 to 40% of the population. And so it is impossible to meet this objective. So what would you recommend to these Ministry of Health officers? What would be your recommendation? Why should they transition to the kinds of protocols that you explained in your presentation? Over to you, Dr. Cohn.
Thanks so much, Dr. Ordonez. I think this is a great and obviously timely question. One thing I would say is, particularly during times of crisis, having a simplified, very limited and clear and safe formulary makes the potential to both stock and distribute medicines much more feasible. When I was working in MSF, I was working in how to manage HIV in unstable environments. One thing that we very quickly came to realize is we needed to focus on a single fixed dose combination and provide as much stock as possible to the lower level facilities so they could respond rapidly and provide even longer extended refills when they saw that crisis was coming or was here. And in this way, we were really able to use the very simple, limited formularies, simple protocols, and fixed dose combinations to smooth out those supply chains, limit what we stocked at the health facilities, and be able to rapidly push that medicine out to the patients who needed it, even during times of crisis. So I would say that actually COVID just highlights how much we do need to move towards these more simplified medicines. And as an infectious disease physician, this will unfortunately not be our last pandemic.
Pedro, this is Don. I have to apologize. I'm not getting an English translation. So perhaps I'm missing something, but if you could just repeat the question, or just be aware that I'm only hearing Spanish.
Dr. DiPetti, you have to put yourself in the original audio so that you hear, because Dr. Cohn was actually speaking English, so I can't interpret into English from her English. Can you hear me now, sir? We have both channels open. Jennifer Cohn is actually speaking English, and we have interpretation into Spanish. So all you have to do, sir, is in the interpretation button, put English, and if you're English, you'll hear whatever you want. Yes, Jennifer.
Where is the button for
Está en el menú
in the menu down at the bottom.
Yes. Don, if you just go to the icon, the globe interpretation icon in the bottom of your screen, press that.
Oh my goodness gracious.
There you go. No problem. There you go.
Unbelievable.
Pedro, do you want to repeat the question for Don?
No se preocupe.
We're good. We're good.
Doctor, can you hear me now, Dr. DiPetti?
Yes, and I heard Dr. Cohn's response, and I totally agree. It was what we've learned from
I think that
It's
Jenny,
unbelievable.
Dr. Orduña says that Jenny has taken us to a very interesting, because the public in this webinar is very particular. We have the procurement officers, the medications, we have those who decide on the forms. And so it's very important for them to be hearing firsthand from you, what are the important things that have to be done now? And maybe we might find ourselves in a chaos because of this question of the COVID-19 and sometimes not know how to respond. And I think that this is a very timely moment, because we have other conditions that we have to explain later. But I wanted to ask Dr. DiPetti the question of the 64,000 or million pesos. Sir, why? The question of the dosage combinations was a myth. Clinicians weren't quite satisfied with this question. They didn't really feel very sure of how to use combinations with a fixed dose on the one hand. And on the other hand, the price of the fixed dose combinations were more expensive in many places. So the patient didn't know much about this, of the fixed dose combinations.
Our clinics, in the waiting rooms, and actually in the individual examining rooms. And it can be embarrassing at points in time when a physician, including I've probably done this myself, changes a medication and the patient actually tells me, but Dr. DiPetti, that's not in the algorithm. I actually call that success. That's when we've actually won, when the patient is also engaged with us and correcting us or guiding. And again, now it really is a team, a physician or provider, healthcare worker, patient interaction. So I know it's scary, trust me, it is very scary. And I'm old enough to not want to change anything. On the other hand, I'm also trainable, and I'm learning with others, including, as I mentioned, our HIV colleagues. The same thing goes true with using initial two medications at once, either as single pills, but again, better yet, as fixed dose combinations. That's a paradigm shift for even my generation. I was taught in medical school never to use a fixed dose combination. And why? Because, well, you can't titrate each individual medication to the maximal doses and side effects and a million and one reasons. And I have to admit, that's wrong. That's clearly wrong. And again, that's where there's an aha moment, where we always have to keep our minds open. We've got to be open for new evidence. We've got to be open for new paradigms and new ways to treat the old disease states, if you will, including also now new disease states, such as the pandemic we're in now. So I understand the concern. I have been I've had the same concerns in my career. And I'm trying very, very diligently to look at the evidence, show that, and the evidence clearly shows combination therapy, whether it's fixed dose or single pill, is effective. It's safe. The individuals we're treating with hypertension, their initial blood pressure levels are so high, even at 140/90, we're rarely going to do harm. And again, it is certainly possible, but it's the exception. It's not the rule.
Por favor, apagar los micrófonos, las personas. Si nuestra técnica Sonia, por favor, apagar el micrófono de la persona que habla.
There's someone in the public that has their microphone on, and it's being really difficult to follow. I think we've advanced very interestingly with two presentations of the problem quite significantly. We're making recommendations to the health ministries. We're recommending also those who do the purchases and those who manage the drug policies And we're also recommending what the clinicians should do. So we're at a truly important moment. The heart's model is becoming the cardiovascular model for the region. We're advancing in a number of countries that are using this same approach, and we're beginning to understand the calling you made at the beginning of this webinar, saying that 10% of control is unacceptable. 10% control of hypertension is unacceptable when it's one of the main risk factors of premature death. But then we had a second aid that came in here, and that is that at the end of 2019, WHO published its new list of essential medications and for the first time included the fixed dose combinations. This was the time when this was something the ministries had been waiting for. We can't do anything until WHO tells us that the fixed dose combination should be included, then we're not going to include it. That's what the health ministries were saying, but now we have the fixed dose combinations. But we also have a mechanism to assist the countries to have more competitive prices and better quality medication. So in that moment, we have a fabulous instrument that came in for the region of the Americas, which has been the Strategic Drug Fund and medication inputs. This fund had always worked only in areas like communicable diseases, HIV, AIDS, TB, insecticides, and some types of very expensive medications. And however, it had not really started working in the field of chronic diseases and particularly hypertension. And for the first time, the strategic fund begins to work with a new list of hypertensives, which includes that fixed dose combination, which is a tremendous result. And I want to say it in a loud voice. I want to congratulate the colleagues from the Strategic Fund because the progress attained is immense and is now making available for the countries a new resource to have less reasons to say that we can't advance in this field. So I want to introduce my colleague, Christopher Lin. Christopher is head of the Drug Strategic Fund of PAHO. And Chris is going to help us understand the role of this fund and will help me lead this second part of the session. Chris, we now have the therapeutic algorithm. We have sufficient evidence to say that we're in the right direction. And now our clinical experts have told us why it's important. So how can the strategic fund help us in this? Chris, you have the floor.
Now, thanks, Pedro and Khalid. It's really great to be part of this forum. Just want to confirm if I'm audible, if you can hear me. Thumbs up.
Yes.
Correcto,
yes.
le escuchamos. Correcto, muy bien.
Excellent. All right, thanks, Pedro again, and it's great to see you, Donald. It's been almost a year since we last met in person. So great to see you again. So once again, a very good afternoon to everyone, and I'm glad that we have this opportunity to share with you today about this PAHO Strategic Fund and how we've been working programmatically with the HEARTS program, right, to deliver upon this latest update in terms of the anti-hypertension medicines to support the HEARTS program. And of course, everything that we talk today is not entirely a full representation of what the Strategic Fund represents and what we do. So I do strongly encourage that for those of you who do not really know about the Strategic Fund, to visit our website after this session itself. There'll be links that's going to be provided in the materials that will be circulated. So a quick introduction, I'm Christopher Lim. I'm the chief of the Strategic Fund based out of Washington, DC. And I'm glad today that I can share with you the updated list of anti-hypertension medicines that's been added to the Strategic Fund's portfolio, as rightfully mentioned by Pedro, which is aligned to the treatment protocols of the HEARTS program, as described by the earlier speakers. And between myself and my colleagues, we will try to cover 3 specific areas, right, which is in continuation of the earlier presentations, to be able to demonstrate that how we can actually contribute to the 3 A's specifically, right? So the access, the availability, and the affordability of medicines, as described by the Sane algorithm, as described by earlier on by Dr. Jennifer. So the 3 areas will be, first of all, the journey of how we have actually arrived here. All right, what are the steps and what's the process that we've gone through, right, to arrive to where we are today. And also a description around the rigorous process which the strategic fund goes through from a quality governance and control perspective, and also at the same time ensuring commercial competitiveness and transparency to bring about maximum value proposition to our member states. And the last area which will be touched on will be around the overall process in terms of next steps and how member states and other public health institutions can work with the ministry, PAHO country office, and of course the strategic fund to maximize this collaboration. Next slide, please. All right, as you could see here now, the HEARTS program really started with initially 50 molecules and 100 concentrations back in 2016. And progressively over the years, we have actually narrowed it down to 9 molecules and 50 concentrations, as you could see here today, right? Which is very much aligned to the treatment protocols recommended by WHO and the HEARTS initiative. Now, this is the result of a programmatic work which we have been doing, right, with the HEARTS program in terms of aligning the best practice, building consensus-based. So the word here is actually consensus-based, right? With various participating countries in terms of aligning of the strategy, right, to standardize treatment protocols, having fewer branching and more linear protocols as described earlier on by Dr. Don, and the usage of fewer drug classes, and also the fixed dose combination, which was introduced in 2019 itself into our latest portfolio. Next slide, please. Now I'll hand the time over to my colleague Murilo from the Medicines and Technology team, who would bring you through the rigor of our process, whereby we actually ensure quality governance, assurance, quality control, in a process whereby we can actually ensure, right, that we deliver quality medicines, quality assured medicines to our member states, right? And also by doing in the process, right, of doing this centrally and upfront of the process itself, we hope to demonstrate to the fact that it actually reduces the need of individual countries to do overlapping qualification, and therefore, as a result, showing the benefits. Right, this is one another example of a benefit proposition whereby shared services can be achieved through working with the strategic fund. So over to you, Murilo.
Thank you, Chris. Yo voy a hablar en español, mi presentación. Quería inicialmente comentar.
I'm going to speak Spanish, and I first wanted to mention that the idea of briefly showing you this information related to quality and quality assurance of products, which will be available. Here, this is just a brief introduction to show that what we do for quality assurance is mainly related to the evidence-based selection and the clinical protocols approved by WHO or recommended by WHO, as well as the essential drug list of WHO. So based on this basic criteria, we choose the products that will be included in the strategic fund list. And once we have the providers, we begin to follow a process of assurance that ensures that the providers and products are adequate. And there's a criteria of technical specifications and special requirements, which I'm going to refer to later, where we include all criteria based on international references. Here, we also have, as we said, technical assistance to the countries, because many of the countries have their own specific requirements, often to nationalize the product, or there are technical specific regulatory requirements. So we support the countries, and not only do we just procure the product directly, we also give concrete support to the country and the relationship between the country and the the manufacturer. So we follow the whole cycle: selection, procurement, and acquisition until it reaches the country, including all the delivery criteria, and be sure that the country receives the product internally. All of this is what we call quality assurance, which is, as the definition says, is much wider than just to consider simply quality control. We follow a much wide-ranging concept. In the next slide, we will specify, next slide, please, some details. We first begin to choose a product following the eligibility criteria. So when we speak of quality, we first check to see if it's pre-qualified by WHO. WHO pre-qualification is a program that follows a series of stages, including inspection, evaluation of quality, and so forth. And if it's pre-qualified, naturally, we can take advantage of the experience of the pre-qualification of the product and can add it to our list. If the product has not been pre-qualified by the WHO, we can also resort to other authorities where our procedures have already defined them. It has to consider either a regulatory authority considered regional reference, where we have a support program, and there's 8 in our region, and the surveillance organizations, which are the stringent regulatory authorities that we have, the SFINI. So in practice, we have ways to find pre-qualified providers as well as the non-pre-qualified providers. But in any case, we evaluate the following quality criteria of the product. First, we make sure that we have a product that has proof of registration and marketing in some country from the authorities that we consider eligible. Without a doubt, if it's a generic, we have to be sure to have proof of therapeutic equivalence. And of course, we have to have the good practices, good manufacturing practices certificate that are appropriate and current. The stability studies, the fast as well as the long term, must exist, and also stress tests. Today, cyclic tests are also used, of course, based on the type of product. The specifications of the finished product are essential, and always checking the pharmacopoeia and the identification limit criteria. And from there, we have all the information available for the clinicians, such as the inserts, the information that's in the packaging. All of this is confirmed by us. And finally, we make sure that we know the drug safety profile of the product. There are documents that consolidate all that information, such as the periodic safety reports, as well as the risk-benefit reports. And at the end, of course, we consolidate all the information and follow the product in the market. So we see what happens in time with the use of the product, and if we have a procurement agreement, we follow the product. To summarize, the quality assurance section is done routinely in our work. Thank you very much.
Thanks, Murilo. Next slide, please. All right. So this is actually the latest list of heart's anti-hypertension medicines that we have established long-term agreement with to the end of 2022, which could be procured through the strategic fund itself. I'd like to draw attention to a couple of information here, right? So if you look to the rightmost column that says price, so these are actually the prices, negotiated prices that we have on behalf of member states, and they are in US dollars and they are unit price. So what do I mean by unique price? So meaning to say that this do not include the freight and insurance yet. So these are additional costs that needs to be embedded subsequently to this cost. And also the other piece of information that I'd like to align you to is the packaging. So if you notice, and we've heard from the earlier speakers as well, right? The whole emphasis around multi-month dispensing or replenishment regime. So this is very much aligned to that recommendation itself. All right, so I hope this is another example of how we actually demonstrate programmatic approaches that's been incorporated right into an integrated process that works with PAHO, within PAHO, and within the strategic fund itself. Next slide, please. All right, so over this slide here, you could see, really the power of economy of skills, the power of pool procurement mechanism itself. As you could see, we actually managed to consolidate the demand across the entire region and collectively source, right, from an international pool of quality assured producers and effectively negotiate for extremely cost competitive and supply assured agreement. As you could see here, some of the potential savings really could stretch as high up to 99% of potential savings, right, compared to the cost which is paid by certain countries in comparison to that of the PAHO strategic fund. Next slide, please. So now you'll be wondering, now what do I do next, right, in terms of in order to capitalize on this program itself? So I'll help you go through a couple of steps which you will need to be doing next, right? So the first thing first is, and I think it's been mentioned in one of the question answers as well. First thing is to ensure, right, to check back with the treatment protocol, national treatment protocol of the anti-hypertension treatments within the country itself, and make sure that it's already aligned, right, to the recommendations of the HEARTS program. And then subsequent to that is to ensure that the national medicines formularies is also updated to include this prioritized and focused list of medicines. And although PAHO Strategic Fund primarily works with the Ministry of Health and any other nominated national government institutions, but if you feel that there is a need and there's a possibility to collaborate with us, my recommendation is for you to reach out to the representations from the ministry or the PAHO country officers or directly to us, right, to schedule discussions and clarification session. So once all these prerequisites are done, what we will actually urge you to do is to forward us a forecasted demand of the next 12 months within the country, within the organization itself, so that we can further collaborate and plan with the producers and freight forwarders in order to make sure that the medicines are actually delivered on a timely basis. Next slide, please. And so I just want to, I guess we have emphasized several times around, demand planning, demand forecasting and consolidation. So this slide, I hope to emphasize the facts, the importance actually, and also the benefits around, this demand planning and forecasting exercise, and why is it an important cornerstone to our program. So first thing first is that it actually allows us and put us in a much better position, right, to negotiate with producers and freight forwarders. As you could appreciate, by channeling the demand across the entire nation and the region, that actually allows us to utilize this economy of scales to negotiate not just for better pricing, but also better service level with our producers and freight forwarders. Now, the next benefit is definitely the assurance of supply. With the advanced estimate of the demand and the delivery dates, it actually allows us to work with the manufacturers to secure their production capacity and also the transportation assets of the freight forwarders ahead of time, so that we can actually ensure that there's assurance of supply, especially in this current situation where capacity constraint is faced everywhere, and you potentially lead to delay of shipments and receiving of medications. Now, one other advantage to that is that by planning ahead, it gives us the ability to actually utilize what we call multi-modal transportation, which is essentially a mixture of air, land, and ocean transportation, right, that allows us to optimize in terms of cost and time. And just to provide a couple of data points, right, so by switching from air transportation to ocean transportation, that can potentially save us up to 400%, right? It's 400% in terms of transportation costs. And as, of course, a reduction in terms of carbon footprint by, at least 90%. Now, the third benefit is allowing us to optimize in terms of resource planning. So one of the things that probably wasn't quite emphasized earlier on was the availability of this interest-free loan up to 60 days, which the strategic fund actually provides to member states, which of course is an important element, right, at this point in time that provides options to countries and institutions for them to optimize on their very limited resources. So again, advanced planning allows us to be able to better plan around the usage or the utilization of this very critical financial resources, and also the allocation of our credit lines. And last but not least, by planning ahead, it allows us to strengthen our technical cooperation capacity, all right? And by allowing us to work with you programmatically from various technical perspectives, right? Especially around ranging of discussion of what treatment protocols to use, how much medicines, when to buy, when to place an order, so on and so forth, so that we could actually cross our others, fine-tune and course correct along the way, and that gives us time to do that. Next slide, please. All right, I will now pass the time over to my colleague from the procurement team, who will then talk through how strategic fund ensures commercial competitiveness and extensiveness, right, through rigorous, transparent international sourcing and bidding process, so that we can actually, help member states achieve the best and the most optimal results from a sourcing and price establishment standpoint. So over to you, Jody.
¿Me escuchan?
Sí, adelante.
Can you hear me? Yes, go ahead. Well, it's a pleasure, and good afternoon to all of you. We have
It is a pleasure to be with you. I see some familiar faces, others are new, but it is a great pleasure to finally be able to present the long-term agreements. And some of the participants that are here, they all have the background and the ability to understand the procurement portion here, and we will explain how long-term agreements have been established, those that are currently in force. Given the demand from 6 countries who participated, Argentina, Chile, Cuba, Panama, Mexico, and Trinidad and Tobago, with these amounts, we established an estimated demand in order to be able to start and do some engagement and identify potential vendors or suppliers. So with our team, our procurement team, and also with the quality team, Morillo and others, we started analyzing to determine which were those that potentially met our criteria, and we came up with a list of 48 international manufacturers who were identified, and we had some informal communications with them to explain that this list would be published. We also participated in some forums in Europe and other places where we explained that we were going to open a bid with the products related to the Hertz initiative. So then the list was published eventually, and as part of the bidding process, the tender process, there was an open platform where we could invite the manufacturers who had expressed interest, where we would clarify all the questions. And in this case, we had over 50 people connected representing the industry to understand how we had come to the quantities, what countries were participating, if there were restrictions, limitations, the terms of payment, legal terms, et cetera, et cetera. Once the bidding process was closed, there were no more questions. And then the questions that had been asked and the answers were shared with the manufacturers. When we received 73 bids, including the financial aspect together with the technical aspect, Murillo was telling you how the technical proposals are first evaluated. Those proposals that don't pass, um, from the technical standpoint, they are not considered, and we don't even consider those prices, only those who pass the technical portion. After both the technical and financial reviews or evaluations, we do a final assessment, and out of that, 20 products were selected from 9 providers. And this was the value per money. And we looked not only at the price of the product, but also the language, the capacity, if there were minimum amounts where the manufacturer was located, if they had some adjustments that needed to be made in the language and in the terms and conditions that were accepted by them. So out of these 9 long-term agreements with the 9 for the 9 products are in place, and we are ready to respond to the needs of the member states. Based on this demand and in agreement with what Dr. Pedro was explaining to us, is what we expect is that this will be an agile, expeditious process. And we have been able to do this with 6 countries, and now we have 16. And if countries are interested and we see that there is more demand, we will then continue to identify new providers where we will have even better proposals given the scale economies there. So this was as an explanation, especially for those of you who are attending and belong to procurement departments. So this is how we're doing it. So from procurement, how are we going to support this initiative? Well, first of all, market intelligence. We're always on the lookout for new providers and see how it's working out, if there are possibilities of obtaining better value for the money. And we also have a procurement strategy for not, we don't do a full international tender for every product. I know there are some products that have patent issues or other procurement issues. But once we have all the market intelligence collected, and then we have a request for bids for products, depending on the product, depending on the interest. But once the long-term agreements are established and given the response of the countries, so per country, according to their amounts, we have documents where we have everything, the useful life, the cost of freight and insurance, the total amount that needs to be transferred. And we also have the whole logistics for the whole follow-up from the origin to the airport or the maritime port, depending on how it will be shipped. We also have periodic meetings with those providers with whom we have long-term agreements to see what performance is like, if there are availability issues, if there are delays in the shipments, if the quantities are sufficient. And we do this systematically. And all the time we review the contracts with the providers, or sometimes it's necessary to make adjustments to the contract, etc. And now, for example, people may think, oh, well, all this sounds great, and I like the way PAHO has established long-term agreements, and I feel fine with this kind of support. But then what is the process I need to follow myself? As Chris was mentioning, first is through the country office making a formal request. This request will go into the PAHO's system. And as part of this request, there is a technical review and a team assigned to reviewing the quantities, the product, to understand whether there is some language issues and requirements, etc. If the process is all clear, so from procurement, we go to the provider with whom we have an agreement and we ask about availability. And you see in the lower part, if we have a long-term agreement, then in about 40 weeks, we have a price estimate if there is no long-term agreement, because maybe there's a product with a restriction and then we need to open it to a tender additionally, and that's how we do it there. But for most products that we have with which we have long-term agreements, there are very few restrictions. It's an open market where we and for some, and we have more than one product with long-term agreements. And so within 1 to 4 weeks, you will have the price estimate ready for you. This price estimate will be shared with the authorities, and all of this going through the country office. The authorities review the terms, the conditions, the product, the price, etc. And in case there were an approval by the authorities to continue onward with the process, then you would approve it. You would transfer the funds, or you would request a line of credit. Chris has more information about this. So if the country says, well, I would like to use the line of credit, and then I will be able to reimburse and follow the procedures, and then procurement issues a purchase order. Key times are the time between you receive the price estimate and the time you confirm the request. If it is within the 30 days, uh, even though the prices of the product are guaranteed to the end of the year, it is true that due to the logistics of COVID-19, we've seen some changes, and some providers only guarantee the freight and insurance costs for 1 to 2 weeks. If we do the conversion of the estimate to the purchase order within that period, we will be able to proceed, and in 1 to 2 weeks, you would be receive a copy of the purchase order. If that estimate is in the country for approval for more time than that, then you have to go back to the provider, especially to make sure that the freight and insurance prices are still the same. If the product is in stock, you would have your product in the port or airport you have chosen between 8 to 14 weeks. Nationalization costs will follow, and also the cost from the port or airport to the warehouse. If the product needs to be manufactured, or if you have some labeling issues where the labels need to be translated into Spanish, for example, then we would be talking about 8 to 10 weeks of manufacturing, maybe a little more, and then we would add to that transit. And so transit is about 2 weeks to have all the shipment documentation ready, etc., and share it. We have instructions for shipment for each country. Each country requires different documentation, and then we make the orders tailor-made depending on whether a license is required, if approval of the shipment is required, if additional documentation is required, all of this is tailor-made, individualized, and so that's why we have that period of 8 to 14 weeks. And since we're running short of time, I won't go into many more details right now, but if you have any questions about the process, about the information that we have shared with you, let me say that we are at your disposal. But again, it is a pleasure to see that the Hertz initiative, when we started talking with Pedro over a year ago, we have it here. It is a reality now, and we are very happy to be able to support you with this initiative from procurement. Thank you. Thank you. Thank you very much, Jordi and Murillo and Chris and all of you for this second part of our seminar. I'm taking a look at the chat and it's crazy. People are sending me questions not only through the chat and the Q&A, but also WhatsApp. But people are very excited. Oh, finally, we have the medications there. Some countries are saying, well, we had the protocol in place. We were all in agreement, but we ran out of medications. So this country in particular and this region documented when they had the issue of the medications, they saw how the hypertension control also went down. They had improved their control levels, but as soon as there was a stock out of medications, the control levels fell. So having a medication is vital, as vital as having a protocol. So as Jordi was reminding us, we've done our homework. It means we have evaluated the evidence, right? And then we wrote a methodology of how the countries can adopt the protocols. Then we trained the primary health care personnel. Then we advocated with politicians and decision makers as to why the program should go to that level. And finally, we were able to make long-term agreements to have the medications. And and again, I emphasize quality medications are competitive at competitive prices. So having quality medications gives us the assurance that what we are doing is of quality and following best practices. And this adds another dimension. As Dr. Cohn was mentioning in the beginning of the webinar, it is a very important uh, thing. Equity is another issue. Some populations who don't have access to the resources always had very limited pharmacopoeias. And so it was always the cheapest, not the best quality medications. And of course, those groups require better levels of hypertension control. They were more vulnerable to having having a simplified, sane algorithm is the way to go. Um, we have come to the end of our time. People are visiting the website, so maybe we could include some of the links to the procurement um, uh, 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 people. But I think you have said key things here. So if we're able to control hypertension using these protocols, we will reduce the number of events and the burden of cardiovascular disease. As we know, the main cause of mortality and disability in this region is precisely a cardiovascular disease. So we need a wider variety of medications. Some of those medications we need more than others, and we need to be clear about this. But we need to have a small formulary, but there is a lot of competition. So PAHO's strategic fund makes a practical contribution. It is a model to follow because the countries in their pharmaceutical policies should be emphasizing the fact that people should have medicines available that are quality and that are affordable. I am going to give the floor back to Christopher Lim for him to give us a final message about this latter part of our webinar, which has to do with the practical aspects. Over to you, Chris.
Thanks, Pedro and Khalid. Right. I hope this is really just a beginning of the journey that we have demonstrated, the value propositions which member states together with other organizations who are interested in capitalizing upon this program, right? That can work with PAHO, and also from a strategic fund perspective in terms of stressing the 3 A's that we can deliver upon, right? Which is the access, the availability, and the affordability part of quality assured medications. So I've also put into the link, rather in the chat itself, the link to the strategic fund itself. So for those of you who want to find out a little bit more and understand the work that we do, and how to actually collaborate with us, feel free to reach out to that website, and that should give you the information on how to work with us and the next steps. So once again, thanks everybody for your kind attention and collaboration. And over back to you, Pedro.
Muchas gracias, Chris.
Thank you, Chris. Jordi, there's a question. It says, well, you said that we had 6 countries that had shown their intention to participate in the fund. So the question is, what happens if more countries participate? Does it mean that we will have even more competitive pricing? Is that true? Yes, in fact, that's true. The message that Chris was emphasizing in terms of demand is true. There are providers who did not submit their bids because the amounts were not attractive to them, or because there was not a firm commitment. But if we are able to plan appropriately and be clear with respect to demand, understanding timelines, etc., we don't need to have 80 products. We think that with the amount we have currently, we can reach a large portion of the population. And if there's more interest by other countries, we will be able to obtain better conditions and better prices. But yes, price in itself, I think we need to talk about value for the money. It's not about saving a few cents here and there, but we have guaranteed quality. And Murillo has emphasized the process we have. We know when we have done market studies that there are products that are more economical, but they not always have guaranteed quality. So that's a first thing. Secondly, more value for the money means that we have strong delivery times to have the language things in Spanish. If a provider has minimum amounts of the lot, then having the inserts in Spanish is a challenge also. That to have a manufacturer that has offices in our area, in our region, that can, so that they can respond to our needs. So if we are able to have not only the 6 or the 16 or whoever want to join, we are sure we would attract more manufacturers. We have a presentation that was not eligible, but these people are willing to register with a regulatory agency, but they asked how much was the quantity that PAHO intended to buy within the next 2 years. And this is the kind of information that will be useful if we have clear demand, so that the providers may begin to the to apply for registration, etc. All of these things make a difference. So having more interest is important. Well, thank you very much. Excellent. We're coming to the end. We have maintained a stable number of participants. So we have around 200 people. So we can say that we have a protocol, we have a methodology for the protocol inspired in the HEARTS model. We have a list of essential medicines and a list of prices from the strategic fund. We have 16 countries implementing the initiative, and I think we are ready to continue. And let me tell you, I'm throwing out a challenge for Jordi and Chris and Murillo. And so this is when we start with the devices. That's another topic where we have a great need. And I promise you, we will bring this up in the near future. I want to ask the whole number of panelists and everyone who's participating to turn on their camera so that we can take a picture. Those of you who can turn on their camera, please turn it on so that we can take a group picture. Gloria Arancha, please. Uh, okay, make sure you're looking good for this picture. This is a historic day. We are launching the list of medications with 16 countries implementing HEARTS. This is a historic day, and we hope that we will continue to increase the number. Arancha, you take a wonderful picture. Thank you all for participating, and we are open to more conversations, more discussions. The next webinar will be devoted to another product, the cardiovascular risk calculator. We will have an app that we will launch to teach you how to use the um, cardiovascular risk app. Okay, Arancha, are you ready? Oh no, I'm having a little bit of a technical issue here. Okay, thanks to all the panelists.
Jennifer.
Thank you, Jennifer. Thank you, everybody. Thank you, Don, for being with us. Thank you, Chris, you and your team. And if you have questions about interprogrammatic work, come to the session. Learn how we do interprogrammatic work and how we coordinate together in order to provide support to our member countries. We have two new faces, Livardo and Angelo, who are participating. There are two new members of HEARTS. Greetings to all, to the administrative team who supports us and allows us to have a quality webinar like we had today. So good afternoon, good evening, good night, whatever, wherever you are. It's been a pleasure to be with you. And we'll see you next time in our next webinar, as I said, devoted to the app, a phone app, which can also be used on your desktop or other mobile devices. And this app is about risk assessment. Again, thank you and goodbye.